Hi, Dr. Gullberg here, continuing our internal medicine lecture series. Today we're talking about atrial fibrillation, very common problem that we see in the office as well as the hospital. Currently about 8% of Americans over age 80 get atrial fibrillation. So you're going to see this a lot if you're in internal medicine practice. Patients with atrial fib do tend to have, I think, a poor quality of life in general, generally a little more fatigue, that type of thing. Causes, of course, are hypertension, heart disease, either coronary disease or valvular disease, chronic lung disease, hyperthyroidism, and of course, never forget about alcohol and alcohol abuse. Those are all common causes of atrial fibrillation. And anytime there's enlargement of the left atrium, especially if there's mitral valve disease, that's a big problem. Once people have atrial fibrillation, of course, they're at risk for stroke. And of course, we use the CHADS-2 score, which stands for CHF is 1 point, hypertension is 1 point, age over 75 is 1 point, diabetes is 1 point, and a previous stroke or TIA is 2 points. So of course, we give low risk is less than 2 points, more than 2 points is higher risk. In terms of looking at the EKG for atrial fib, if it's a fast response, just count up 6-second strips, that's 30 boxes, and you multiply that times 10, and that's going to be the rate. Anything over 100, of course, is considered an uncontrolled ventricular response. Treatment with anticoagulation, of course, is standard for people. We either use Coumadin, we've been using that for years. Now we've got Pradaxa, which is a direct thrombin inhibitor. We've got Xarelto, which is a factor 10A inhibitor. And now we've got Eliquis available. These are, been approved in non-valvular disease causes of atrial fibrillation. And problem with Xarelto and Pradaxa is they don't have a antidote in case there's an excess amount of bleeding like Coumadin has. Rate control, we use generally diltiazem and metoprolol, and then infrequently digoxin, which is old school. Rhythm control, we use chemically with amiodarone or dronedarone, which is Multac, and then sometimes we have to go to Ticacin, which is dofetilide. Big problem with QT prolongation with that medication. If these all fail and we continue to have problems with atrial fib that's uncontrolled, we'll use direct current cardioconversion. And if that doesn't work, then ablation is used for cases that are hard to control. And the electrophysiologists are there waiting to do that procedure if needed. So a little summary on atrial fibrillation. Watch for it. Patients who have it, their quality of life isn't that good. It's not bad. It's just not as good as it was when they were in normal rhythm. Thanks, Dr. Gullberg, signing off.